Okay, it's GIGU. It is Tuesday, week 9, summer 2020. Let's continue our discussion of the prostate. We talked about it. It's in males only. Right, we talked about the zones. The two most important zones are the biggest, the peripheral zone, which is the one we palpate. We'll palpate in lab. Is that next week? I think that's next week. Week 8. I forget when it is. Let's see, this is week 9, but it's really week 7, the end of week 7. So, no, it's on week 9 is when, yeah, it will be this week. See, this is why I'm so confused, because I'm trying to stay ahead with these and I get lost. But this lecture is for week 9. This is Tuesday. Anyway, let's talk about the great paradox. The second most important is the TT kind of zone, right? Because that one hot dog buns around the prostatic urethra. It's called the transitional zone, and that's quite important. So what's the deal with the great paradox? So some facts you have to know. It is a fact that increased prostatic levels of testosterone will cause hyperplasia of all prostate cells. Sometimes it affects the epithelial cells of the ducts and tubes, and the basal cells. Sometimes it just affects the smooth muscle cells of the stroma, and sometimes it affects stromal cells, because there's fibroblasts and there's other types of connective tissue just hanging out in the stroma of the prostate, so it can affect all of those. Another fact is we know that as you get older, your chances of getting BPH increase dramatically. And another fact we know is that as you get older, guys get older, their testosterone levels drop. And that's a very ubiquitous problem with guys. In fact, old patients with BHP have extraordinary low levels of serum testosterone. So you see the paradox? Yeah. Oh, just a side note, the proof, if you castrate, if a young boy is castrated, his testicles are removed, maybe got in an accident or caught up on a barbed wire fence or something, and he lost his testicles, they never develop BPH. So it's definitely related to testosterone. But if old guys lose testosterone as they get old, how can they get BPH? Right? So if older men have decreased testosterone, why do they have such a high prevalence of BPH? That's the great paradox, and it took them years and years to figure that out. And so here's a hint. The hint to the problem comes back to valves and veins. Remember our testicular veins. Remember that was always weird, right? Because the left renal vein gave life to the left testicular vein, but the right testicular vein comes off the inferior vena cava. That was weird. But both of these veins have a lot of valves in it, just like the valves in the lower legs do. And the blood that comes out drains out of the testicles along with testosterone, and along with a little bit of estrogen too. That's where estrogen is made. It has to get ratcheted out, so it takes a while for it to get out, but as long as these valves are competent, no problem. Now do you see what happens? So in people with BPH, it turns out that these valves are shot, and so they have basically, it's almost like a beaver dam here, where you can't get blood out anymore, and the blood will find a way, just like in the lower extremity goes out the superficial system, like the saphenous system, but there is a system where it can get out. And unfortunately, that takes it through the prostate gland. And so testosterone is getting blasted. Even though these aren't making as much testosterone as they used to make, they're getting blasted. The prostate's getting blasted with testosterone from both sides, and that's unnatural. And that's the problem, basically. Let's go through that again with my slides. Got ahead of my slides. So the Gat paper was published, very prestigious paper, a lot of accolades. Didn't get the Nobel Prize, but he probably should have, because that was a huge discovery, a huge mystery. So they discovered that by the age of 70 years, 75% of men developed incompetent testicular valves, testicular vein valves, and that also discovered that patients with testicular valve insufficiency had a statistically higher rate of BPH. So they put 2 and 2 together. And you remember your anatomy from this region. Let's blow this, because here's the prostate in the middle. The other side would be double feeding it. But there is a prostatic venous plexus, and there's a differential vein. Let's blow this up and look at the pipes here. So Leydig cells are making testosterone, and it's trying to swim out of here, but it's not doing very good because you got too much pressure in here, and maybe even a little varicosity going on in here because the valves aren't working. The pressure is built up, and so it's going to find another route. And one of the routes it goes down is this differential vein, and then it passes through the vesicular vein, and some of it goes this way, and so that dumps in into the internal iliac artery. But a lot of it goes this way into the prostatic venous plexus, and it bathes the prostate with way too much testosterone. And that's no good, right? So that's the theory. So with dysfunctional testicular valves, the venous blood can't get out, pressure backs up, the venous stasis. Also, it wrecks the Leydig cells. So another part of the theory that how come the people with BPH actually had lower serum testosterone than men their own age. And the theory is because of the high pressure, the Leydig cells are irritated and bugged, and some of them are destroyed from that as well. And so the blood, of course, is rerouted, just like I said, through the prostatic venous plexus. And yeah, prostate's got way too much pure testosterone coming. And the type 2, we talked last time about type 2 5-alpha reductase, is there ready for it. And it converted it in, it converted it into dihydrotestosterone, which then bound to a receptor and was carried into the nucleus, androgen receptor. And yeah, that's the story. And growth hormones were made, or growth factors were made that stimulated the growth of potentially all of the tissue of the prostate. Sometimes that growth is kind of lopsided, where only the smooth muscle will grow, or only the epithelial tissue, or only the stroma, where the fibroblasts grow and make type 1 collagen. You get these strands of collagen floating around. So the prostate, histologically, BPH can present in 3 different ways, which we'll see here in a second. Right, so there's that model I just showed you. There is another theory. The Smith theory's been around for a while, and maybe both of these are going at the same time. But again, as men get older, their testosterone ratio drops. That means the estrogen is still produced at the same level. And remember, estrogen, I don't know if you know this or not, estrogen is made in males specifically. And this was controversial, actually, until the last decade or so. And so they didn't know this story. When I went to school, they didn't have any idea. They didn't even talk about estrogen in guys. But it's actually quite important. And there is a new implication of estrogen levels with your sexual drive and desire. And so I won't go down that rabbit hole, but estrogen is important. And it's made in the mainly by the Leydig cells, the same ones that make testosterone, and by spermatid. That's right, spermatid actually can produce estrogen as well. And then the epithelium of the epididymis can also produce it. And there's a regulating enzyme in there as well, but we won't get into that. But yeah, so that doesn't seem to be affected, but when you lose testosterone, the ratio of estrogen to testosterone goes up quite a bit. Yep, and that's what it does. The chronic level, so the theory is, so this chronic imbalance with high levels of estrogen compared to testosterone, it stimulates the synthesis. Somehow it turns on genes for type 2 5-alpha reductase. And yeah, that if you have too much 5-alpha reductase, you're not going to miss a single molecule of testosterone. Normally, some of the testosterone kind of just floats around in the prostate and nothing happens to it because there's more testosterone than type 2 5-alpha reductase. But if you have tons of type 2 5-alpha reductase enzymes floating around, every single molecule of testosterone is going to be converted. So that's kind of the theory from that. And of course, once it's converted into DHT, it binds with androgen receptor and it's taken into the prostate nucleus, into the cells of the epithelial cells, the stromal cells, the basal cells, and you get a hyperplasia. Right? There are some other theories that maybe not quite as good, but they've been around. Increased sympathetic tone seems to be correlated with BPH. They're not exactly sure. Maybe it stimulates the prostate cell growth somehow. Chronic inflammation, secondary to cytokines and chemokines, might somehow promote cell proliferation. And we don't know how this works at all, but people with metabolic syndrome, and people with metabolic syndrome have an insulin resistance, and yep, they're at risk for BPH as well. All right, what are some genetic risk factors? We don't really understand these very good as well, but we know some facts. 50% of men under the age of 60 who have had surgery for BPH have a close relative who also has the disease. And it's thought to be a very low level to get the disease. It's an autosomal dominant, which means that one gene from mom or one gene from dad. You don't need both genes to be mutated. One mutated gene is enough. And there's a first-degree male relatives with the disease have a 4-fold risk of passing it along to their offspring. And we won't get into the actual genes because they're really a little shaky on that as well. Some more risk factors. Sympathetic tone we said already. Heavy smokers tend to get it, they think, because that does turn on the sympathetics and can raise blood pressure and do other things. Caffeine, chronic stress. Strangely enough, there's Belushi guzzling some, looks like Jim Beam. Looks like with alcohol consumption, it actually reduces the risk of BPH, moderate alcohol consumption. So it's probably thought to, because it is a depressant, it's thought to kind of relieve stress and relieve sympathetics. What about the clinical symptoms? Are pretty simple. Really, dysuria is the big one, and that's a broad category, meaning we'll look at some of the meanings of that in a minute. During urination, the medical word for urination is micturition, thought to be secondary to the bladder's response to a stenotic prostatic urethra. So there's a beaver dam, right? We've already talked about this. The prostate has crushed the urethra, prostatic urethra, and the bladder has to muscle up to pump the urine out, just like the heart has to muscle up to pump blood when there's a beaver dam in the lungs, or there's aortic stenosis. Same kind of deal, only it's with urine, not blood, but the same thing can result in the bladder. It can get hypertrophied, and then after a while it gets weak and it fails, just like left ventricular hypertrophy. So if you do have a lot of trouble with urinating, don't let it go for too long, because you can destroy your bladder, and that's it. There's no bladder replacement. We can't fix that. So you have to wear a bag like this gentleman here does. And that's not probably the most fun thing to be wearing around. That's pretty disabling, I would think. How about the symptoms of BPH? Well, dysuria. But some of that dysuria is having to strain to go to the bathroom. A post-drip, I mean, all guys drip a little after you urinate. That's just normal. But they drip a lot to the point where they can have to worry about wetting their, like the wetness coming through their pants, that kind of thing. Some feel an urgency. That's a big one. They're frequently urinating all the time. They have to get up 3-4 times in the middle of the night. They get, after they do go to the bathroom, they feel like they haven't went to the bathroom. They immediately, within minutes, feel like they have to go again. And in fact, sometimes within half hour, they do have to go again because they weren't able to empty their bladder. And then when they do go to the bathroom, there's a really not a big, strong stream that comes out. And of course, hesitancy. It takes forever to start. Those are classic signs of BPH. There's a questionnaire that's pretty accurate. You can actually give them, and it gives you a score. And it's pretty accurate for making the diagnosis of BPH. I went into it. I cut it out this quarter because it's just, I mean, you can Google it, and I just need to make more room. I never have enough room. There's so much material. I have thousands of slides for this class. We never even get to quite a few of these slides because there's so much pathology. Digital rectal exam, we'll talk about that in lab more. But when you do it, the prostate feels like the consistency of a racer, if you can feel it at all. Sometimes it's difficult to feel. The induration, that means hardness. So don't ask me on the test. I hit somebody last quarter. What does induration mean? I said what I said in my lecture. I'm not going to tell you what it means. It means hardness. I'll tell you now. The induration of the prostate, or the hardness of the prostate, should be like one of these run-of-the-mill pencil erasers. How about some other testing? You can order a PSA test. That PSA can be elevated in BPH as well. I think we talked about that the last lecture. So if you have BPH and get cancer at the same time, it can be a little bit confusing. You can order for the patient a transurethral ultrasound to look at it and make sure it's not cancer, and that usually comes with a biopsy. Differential diagnoses should have more stars on this slide. I do like this slide. Prostate cancer, of course, is the big one because that can compress the urethra as well. You can get stenosis of the urethra itself, congenital or through tumors. Bladder neck contracture, obstructive bladder stone can do it. A chronic urinary tract infection that's causing inflammation and pinched off or swelling up the endothelium of the urethra. And then watch out for neurogenic bladder. Maybe somebody has a huge central disc herniation. I would think they would have, in addition to trouble starting urination and maybe not good control, they would have pain going down both of their legs, probably burning, numbness, tingling, dysesthesia in the perineal region as well. What about the treatment? So there's 3 strategies for treatment. There's watchful waiting, there's medical therapies, and there's surgical therapies. So let's take a look at some of these. So people would just they get up once, twice in the night, and maybe their bladder doesn't empty all the time. You just kind of wait to see what happens. You don't have to do any treatment and just see if it gets worse. They should be checked to make sure it's not cancer, though. It's not let's see. So if people have moderate to severe symptoms, it's really not recommended to wait because of the potential damage to the bladder. So if you're getting up 3 or 4 times in the middle of the night and you're going to the bathroom, you have to double void. You go pee and then you have to come back half an hour later and pee again. You shouldn't wait. You got to try at least medication at that point. And for moderate symptoms such as those, you do have to start medication. We'll look at these medications here right now. There's 4 types that are used. The alpha blockers and the 5-alpha reductase inhibitors. We'll look at those specifically. There's a combination therapy, and there's this phytotherapy, which is really ridiculous. It's really big in Europe, where it's plant-based and herb-based, but there's just terrible research supporting it, and so I wouldn't mess with that personally. I'm not even going to talk about it any more than that. So what about histology versus treatment? It's important to get a biopsy of the prostate so you know which treatment to employ or which treatment to use. So when they get a biopsy, when the nodules or the tissue, if it's composed of smooth muscle, mainly, then alpha blockers work pretty good. Alpha blocker therapy that blocks sympathetic nerve flow, and so it kind of calms down the sympathetic nervous system and tends to shrink the prostate and prevent it from getting worse. If the nodular tissue, if the lab results came back and the pathologist said, this is an epithelial type of BPH, where the epithelial cells of the glands and ducts are growing wild, probably basal cells are included in there, then there's a 5-alpha reductase inhibitor that you can use. So 5-alpha reductase therapy is the way to go there, which blocks the formation of DTA or DHT. If the nodules are composed of collagen and not that much epithelial tissue or smooth muscle tissue, neither of those are going to work. That's kind of the deal with that. So if medication fails, then you're going to have to do a surgery called a TURP. That's a transurethral resection of the prostate. It's basically like Roto-Rooter, really. You stick a little cable down the penis, and it got a little hook wire that can heat up super fast, and it can cut right through that tissue. There's plenty of YouTube videos on that. You can actually watch it. That's the next. In fact, yeah, we just dropped. I think we just dropped. But I'll put this on YouTube. There's the wire right there. This thing heats up, and it just sliced and diced. This was completely blocked with tissue that looked like this. And this is the prostatic urethra, and they just completely opened the prostatic urethra up again, except for this little. He's going to go back and take care of this one right now. But that's a TURP procedure. It does not look like a fun procedure, right? To get that stuck up your penis, I don't think that would be very enjoyable. But it probably puts you. Did they put? Yeah, they do put you out for that, so at least you won't feel it. But yep, that's the way they do. They just go up there. But anybody see a problem with this? What about the internal urethral sphincter, which is very important? That's under involuntary control, and that's the problem. If they take out too much, they wreck that ability for the internal urethral sphincter to close. So no good. Therefore, if you ruin your internal urethral sphincter and you're trying to have kids and you ejaculate, where does the sperm go? It can actually go right up into the bladder, and that's called retrograde ejaculation. And that's a problem. 75% of the people experience some of that. So you could be infertile. So you don't want to do this TURP if you're still wanting to have kids, because there's a decent chance you won't be able to have kids after this. So that's called retrograde ejaculation. And that, of course, leads to infertility. And they say the orgasm doesn't feel as good anymore because you don't have that prostatic juice coming out anymore, because it goes back up into the bladder. And impotence, we're not sure if they damage the nerve somehow. I don't see how they can do that. So they must have really been off or having a bad day. And if they damage the external urethral sphincter, now you're in big trouble, but you'll be incontinent and you'll have to wear that urine bag. There's a subtotal prostatectomy, or called the simple prostatectomy, where it's basically like the Roto-Rooter procedure, only they remove a lot more of it. It's usually for prostates that are really swollen up and more compression, and the wire's just not enough. You need to physically get in there and start cutting things out. And then a simple prostatectomy, just remove the entire prostate. We had a cadaver, I think it was before your guys' time, but we had a cadaver with one of those who had no prostate at all. Then there's these little silly procedures. There's a laser, and I'm not going to talk about those. Stick with the big ones. Those are still not great research behind them. All right, prostate cancer. This is a big one. Let's start this. It is the most common form of cancer in men, period, end of sentence. 80% of cases are in men over 65 years of age. It may be quickly lethal and kill the person affected, or it may go on for years and years and they'll die of other causes before. Therefore, it's very difficult to manage because of this. So that's heterogeneity, meaning its prognosis, its natural history is very heterogenic. It can go, just like I said, it could kill you really quickly, or typically it takes a long time. But it's a challenge with regard to treatment and prognosis and what to do. The best way to watch it is by PSA levels, prostate specific antigen. There is a Gleason scoring from histological sampling, which is the gold standard. You're always going to get a sample of it anyway at the beginning, so you get a beginning Gleason score, and that can tell you the prognosis, and it can also mark to see or be a marker to see how the treatment is working. And so can PSAs, used as a kind of a marker. If the treatment for the cancer is working, your PSA should decrease accordingly. It's the second most common cause of cancer according to the CDC, found in men. Number 1 is lung cancer. Did I get a problem with only 8%? The most common form of cancer in men, so that's not true. I need to get rid of that. We'll go with the CDC. That's Robbins. Although, that's Robbins as a board book. The CDC's not. CDC says it's the second most common cause of cancer. Lung is still the number 1. It is the second leading cause of death in American men, behind heart disease. That's like huge, isn't it? Prostate cancer is a big problem. And at the time of diagnosis, because it sneaks up on you, most of the cancers have already metastasized, and its prognosis is really bad. Loves the lumbar spine, as we'll find out in the next lecture, which will be next Monday, week 10 Monday. More than 200,000 cases are done per year. Breast kills 30,000 men per year. The mortality rate has been decreasing since the mid-90s because we have better treatment for it, and we're getting better at catching it. It's unlike other cancers. Its age continually or its peak incidence continues to get worse and worse with age. It doesn't ever back off. So age is a definite risk factor for this thing. Lifetime risk is huge for developing prostate cancer, 15%. That's crazy, right? For men, 15% of men are going to deal with this, but most of the time it's when they get up in the 70s, 80s, and 90s and such, if they live that long. Only about 3% actually die from it. There are some risk factors besides age. African Americans tend to have more of a problem with it. If you've had a mother or a dad, I'm going to say mother, I won't touch that. I was going to expand on that, but I won't even touch that in this day and age. So if dad has it, grandpa, if there's a family history for it, that increases your chance. There's the increase. The risk increases inversely with age. So what does that mean? So if your dad got it when he was 35, the risk is huge. If your dad got it from when he's 90, the risk is not really that much of a risk at all. So I do like that. That's been on many of the boards. I like seeing how you think and seeing if you can understand how inversely, what that word means and how that works. Let's see. If you're diagnosed, the decreased age of the person, the more chance you have, as I said, to expand on that. If diagnosed at the age of 50, then the relative risk is 7-fold. So they know that number. Some other risk factors: diets that are high in animal fat and red meat increase the chance for prostate cancer. Diets high in fish decrease. High vitamin E decreases it. Vitamin D, which a lot of baby boomers, and calcium, which you have to take for osteoporosis, actually increases the chances of it. So it's like you want osteoporosis or you want the prostate cancer. So it's tricky managing people who, as they get older. Previous vasectomy, there used to be big scare back in the day on that. In the 80s and 90s, nobody wanted a vasectomy because there's earlier research said it increases the risk of cancer. It does not appear to be true. Like a Cox study in 2002, huge studies could not find any truth to that. So that's probably not true. There is an online calculator that you can use if you want to figure it out. And we already said that location, prostate cancer, PNP, that is the peripheral zone. 65% of the time it grows there. 15% in the TT zone, transitional zone, and 7% in the central zone. The Denonvillier's fascia goes around most of the prostate here. And since it usually starts in the peripheral zone, that's a barrier against for it getting into here. If it gets into here, it's gone, right? There's your capillary system and your lymph system. So you do have a thick fascia called Denonvillier's fascia that does protect or help protect that region. It's not forward though, but usually cancer happens back here in the peripheral zone. If it happens up here, there's nothing to stop it. It can metastasize quite easily. It gets into the seminal vesicles, which are also on the back, around the back of the prostate. That's a horrible diagnosis. There are two types, and I took all these slides out because we just don't have time, but there are two precancerous prostate conditions. I'll just mention the words at least. Prostatic intraepithelial neoplasia and atypical small acinar proliferation are the two types of precancer. And some fun facts, 95% of the time it's an adenocarcinoma, just like the esophagus. It's not squamous cell usually. And the cancer can sometimes invade the trigone of the bladder and result in obstruction, and you can damage your kidneys if that one happens. And it can simulate BPH. Remember the trigone, there's the bladder butterflied open and the prostate butterflied open. Verumontanum is right there, that raised region. And yeah, so you don't want to get a beaver dam in that area. Your kidneys can be in trouble. There's the Denonvillier's fascia. It is a strong barrier and it helps prevent spread of the cancer. It is a one-way barrier, strangely though. If you get rectal cancer, it can go right through that like nothing. So it can infect the prostate if you have rectal cancer. There's Denonvillier's fascia. That's how I learned to say it. I think it's Denonvillier's fascia. I'm pretty close on that. Okay, so that's it. I don't know if you're still with me, but I'll put it up on YouTube if it dropped out. See you later.